Hello everyone, myself Dr. Namrata Vitlani. In this video, we will discuss regarding how to approach a patient with dyspnea. So, dyspnea basically we may divide the causes according to the system involved, such as diseases involving cardiovascular system, diseases involving the respiratory system, and metabolic, and then miscellaneous causes. We may also classify them according to the rapidity of the symptoms, such as acute onset dyspnea, chronic symptoms might be there, and according to the mechanism involved, such as diseases leading to the hypoxia, hypercapnia due to acidosis, and miscellaneous causes. So whenever a patient presents to you with dyspnea, first and foremost is the history. Say if patient is having breathing difficulty, if patient associated symptoms are fever and coughing, so the cause might be the respiratory tract infections involving the lower respiratory tract, might be pneumonia, any lower respiratory tract infection, or tuberculosis. So fever, cough, and dyspnea associated symptoms. Accordingly, dyspnea associated with the non-productive cough, diseases involving the interstitial lung disease, idiopathic pulmonary fibrosis, hypersensitivity pneumonitis, bronchiolitis obliterans, and organizing pneumonia. So also affection of the parenchyma. So the associated symptoms. Other is the acute bronchitis, cough with dyspnea, acute bronchitis, chronic bronchitis. So the associated symptoms. Also hemoptysis, weight loss, evening rise of temperature. It may be present in the tuberculosis. Elderly smoker with weight loss, hemoptysis, breathing difficulty, so might be due to the malignancy. Similarly, large pleural effusion due to various causes such as tubercular or pneumonic effusion or malignant pleural effusion, that may also lead to the dyspnea. So in the history, the associated symptoms might give you to the diagnostic clue. Similarly, if patient is having breathing difficulty along with the palpitation and irregular pulsation and chest pain, so some cardiovascular pathology, such as suppose patient is having dyspnea associated with the irregular rhythm, arrhythmias, might be having the volume overload, heart failure with arrhythmias, various kind of arrhythmias. Similarly, breathing difficulty associated with the pedal edema, paroxysmal nocturnal dyspnea, or orthopnea, so might be pointing out towards the cardiovascular diseases. Similarly, diabetic patient, type 1 diabetics, and uncontrolled sugar control and breathing difficulty, tachypneic associated with abdominal pain, ketonemia, ketonuria, so it might point the etiology towards the decay. Similarly, CKD patients having metabolic acidosis, volume overload, hypoxia, so also having the facial swelling. So associated symptoms might give you the diagnostic clue. So first is the history. Then on the physical examination. In the physical examination findings, various, if you find the irregular pulse, irregular rhythm, then it might be due to the AF or VPCs, so it might point towards the cardiovascular. It is not necessary that presence of arrhythmia is cardiovascular. It might be also present in the respiratory pathology or might be coexisting, but it might give you a diagnostic clue. Other, if patient is having hypoxia, then we may have to rule out various parenchymal abnormalities like pneumonia, ARDS, or ILD, or a volume overload, pulmonary edema, which may be cardiogenic or non-cardiogenic. So hypoxia. If patient is having hypercapnia, then various causes. like COPD, asthma, or neuromuscular junction weakness, myasthenia gravis, GBS, transverse myelitis. So accordingly, like that. On examination, if you find the bilateral crepitations, fine crepitations, which may be present in the interstitial lung disease or pulmonary edema or ARDS or pneumonia or tuberculosis. If you find the rhonchi which are suggestive of acute or chronic bronchitis, suggestive of the bronchospasm, so on the physical examination you may find such things. That may also give you the diagnostic clue. So we are not going to discuss the investigative approach because it is very lengthy, but broadly if we look the causes affecting the respiratory system, what are the various causes? It includes the lower respiratory tract infections such as pneumonia or tuberculosis or ARDS or interstitial lung disease, bronchiectasis, bronchiolitis obliterans, or various forms of interstitial lung disease such as hypersensitivity pneumonitis, acute bronchitis, chronic bronchitis. These are the diseases involving the upper airway: acute bronchitis, chronic bronchitis, upper airway obstruction or laryngeal edema or anaphylactic shock due to various causes. These are also causes involving the upper airway. So, and a large pleural effusion also might cause dyspnea. So these are broadly the others are in the respiratory system, pulmonary embolism and pulmonary hypertension due to various pathologies, asthma and COPD exacerbation. So that may lead to the breathing difficulty. So based on the history, past history, presenting complaints, clinical examination findings and investigations, you will have to correlate the things. Then what are the diseases involving the cardiovascular system? So coronary artery disease and acute left ventricular failure, heart failure, and diseases involving the pericardium such as acute pericarditis or cardiac tamponade, which may also lead to the breathing difficulty. In the metabolic causes, metabolic acidosis due to various etiologies such as decay, or in the CKD we have metabolic acidosis and patient has breathing difficulty. In the DKA, patients are having Kussmaul's breathing, and other is in the metabolic causes severe anemia, and other is all the things are okay but still patient is having hyperventilation, anxiety or panic attack despite all investigative approach. So that is the thing. And pulmonary embolism, acute pulmonary embolism, chronic thromboembolic disorders, that are also various etiologies. In acute onset dyspnea, if we see, then it is acute asthma, COPD exacerbation is there, then cardiac tamponade, tension pneumothorax, pulmonary embolism. All these are very acute onset, and while the chronic obstructive airway disease, they are relatively long standing, and if it the symptoms are not controlled by the ordinary treatment, it is the exacerbation of the symptoms. So, and if we divide it by the mechanism involved such as hypoxia, so various cardiorespiratory diseases such as causing hypoxia such as pneumonia, ILD is there, ARDS is there, pulmonary edema is there, heart failure is there. Then if we look at the CO2 retention, then asthma, COPD, neuromuscular weakness such as myasthenia gravis, Guillain-Barré syndrome, transverse myelitis. Then inadequate oxygen delivery such as in obstructive shock, such as in pulmonary embolism, tension pneumothorax or cardiac tamponade or severe anemia. And miscellaneous causes are panic attack and hyperventilation syndrome or anxiety. So these are the major causes of dyspnea. You will have to approach the patient based on the history, clinical examination findings, and then further confirm it with the investigations. Thank you, and treat accordingly. Thank you.